Good morning, everyone. Thank you for coming out so early, and everyone looks bright-eyed and ready to go. For starters this morning, we're going to talk about restless leg syndrome, a very, very common condition, and unquestionably, there's a huge percentage of patients that you've seen that definitely experience this on a regular basis. Certainly impacts not only them, but when we conduct sleep studies, you'll see a lot of correlates, and it's always nice to understand the conditions that we see even better. So what is restless leg syndrome? And this is certainly a common question, and oftentimes it takes some defining in order to specifically know if that's indeed what you're dealing with. The criteria for restless legs, the key hallmark is this sort of uncontrollable urge to move the legs, okay? Oftentimes it's at bedtime. It's more commonly worse with any period of inactivity or rest, so that's why you can notice it on things like trips on a plane or riding in a car for longer periods. People will notice it then. Kind of those prolonged states of immobility. So it's typically associated with a discomfort, okay? That can be described various different ways, and we'll talk about those in a few minutes. And there's definitely a diurnal pattern to restless legs. So while you can have daytime symptoms, certainly, and a lot of people do, it is more prominent at night or in the evening hours. Typically, the patients experience some degree of relief with movement. You have to be very specific about that, because when you're asking a patient, does this get better if you get up and walk around, then oftentimes they'll say, well, no. And then if you dig a little deeper and find out, okay, well, does it get better while you're walking around? And then when you go back to bed, you notice it again? And that's when they'll commonly say, yes. So, they'll confuse that question about does it get better with walking with, does that do away with it? And it doesn't do away with it, it's just better while you're moving and walking around. And a lot of people will experience this, especially early on, but they'll say, but it doesn't really bother me. I have this, and I move my feet and legs quite a bit, but it's not to the point that I want to do anything about it or investigate further. Typically, it's in both legs, but it can be in just one. It can also be in the arms. The classic is for it to be in the legs, but it can be in the legs and arms, and even sometimes primarily just in the arms, which of course is a difficult scenario in terms, because restless legs is not high on your differential diagnosis list. Someone just comes in with arm complaints, but it's definitely something to keep in the back of your mind. It's definitely associated with periodic limb movements of sleep. We'll talk a little bit more about those in a few slides. We already talked about how you can notice that during those daytime situations. And some people even, that's the biggest problem for them. Really complain of it necessarily at night, but those periods of prolonged inactivity or rest are really what get to them and bother them. In a lot of patients, at least probably half or more, there's a family history, and we've started to identify some of the genes involved and implicated with that. And there's definitely a high concordance in monozygotic twins, so identical twins, you definitely see a lot of those where both individuals will have that. So what causes restless legs? Well, specifically, we don't know exactly. Dopamine is involved. Okay, it's that's the neurotransmitter commonly implicated, and we'll talk a little bit more in a few slides about iron deficiency and the association with restless legs. And iron deficiency is definitely tied in with dopamine synthesis. Prevalence is estimated at 1.5 to 2.5, approximately 2.5% in the U.S., but depending on some studies, it can be up to 15%. So, yeah, it's definitely very, very common. And it certainly increases with age, no question about it. And you do see it more frequently in females, about 1.5 times more frequently in females. The descriptions that people use, it can be almost anything, okay? Probably the most common two are it's a creepy crawly feeling, or when you ask if they take a long pause and it's like they're really searching for the words, very commonly that's restless legs. So people have a really tough time defining exactly what they feel, but a lot of people will say it's just sort of this, it's an ache, or it's like, and commonly they'll say, it makes me feel bad so that I have to move my legs. So it's funny that factor will come back up in terms of the descriptions, but it can be anything. One of my favorites is people have referred to it as a toothache in the legs. So, you know, it's any kind of vague discomfort, really, though, where you really need to consider restless legs. Among the other conditions that can mimic, or things that would need to be considered, claudication is vascular disease in the legs. Some of the differentiating factors there, though, are claudication commonly is brought on by activity. Okay, so, and it's more during the daytime. So this is more like people will complain of a discomfort in their leg, and it's brought on when they're walking. They may say, you know, after I walk like a couple of city blocks, ooh, I start having this significant pain in my legs. That points definitely more toward claudication than restless legs. Arthritis, these individuals will oftentimes complain of aches and pains when they're lying in bed. So it's very important to say, you know, are these aches and pains more all over in the legs, not necessarily in specific areas, or is it confined really to the joints? And of course, arthritis, more commonly, they'll notice that even though it may hurt, feel like it hurts throughout the legs, they can definitely tell the bigger issue is definitely within the joints. Painful peripheral neuropathy, it's not uncommon to see that along with restless legs, so they certainly can coexist, but oftentimes painful peripheral neuropathy is noted more when people lie down in bed at night. So you can help differentiate that by asking, okay, what is that sensation? If they describe it as a numb, tingly feeling, it can be either or, but you hear a lot of that with peripheral neuropathy. And certainly, sometimes it's difficult to tease one out from the other, so sometimes they need nerve conduction studies to help look at that, and then you address that and treat that and see if they're still experiencing some of those same symptoms. But definitely very common condition, and one that certainly you can see along with restless legs. Lumbosacral radiculopathy is where you get nerve irritation, the spinal nerve coming off the spinal column, most commonly from compression, like with the disc herniation. And that can be a lancinating, kind of sharp shooting pain going down the legs. And often those individuals will notice that more at night as well. The neuroleptic medications that people are treated with for things like schizophrenia and bipolar disorder, sometimes things like that, definitely can, over time especially, can lead to a condition called akathisia, and that's a motor restlessness where they just feel like they have to move a lot. And it's easier to mask that during the day because obviously you can get up and walk around and move and you're more active, but they can also experience it when they're in bed at night. So you definitely want to look at that medication history. And then probably the most common thing that you'd want to consider along with peripheral neuropathy is nocturnal leg cramps, okay? And to differentiate those two, a lot of times you will have the description of, I feel cramps in my legs at night, even when it's restless legs. But then when you dig a little deeper and say, okay, are you actually experiencing like Charlie horses, like where you feel like the muscles are tight? Then a lot of times they'll say, well, no, it's not that. It's just it hurts. And versus nocturnal leg cramps where they say, oh yes, it's the actual muscle and I have to work it out to feel better. So a lot of medications can help predispose to nocturnal leg cramps. The oral contraceptives, diuretics, the different classes, both the hydrochlorothiazide, the kind commonly given for high blood pressure, but also Lasix and Bumex or furosemide, bumetanide, the ones for mainly getting fluid off. You can see it with any of those really, because certainly anytime you're giving diuretics, you can alter electrolytes and things like that. IV iron infusions, raloxifene is a medication for osteoporosis, and also some of the long-acting beta agonists like you use for asthma or COPD. They can also contribute to nocturnal leg cramps. Statin medications for hypercholesterol, that can certainly be seen in association. And also sometimes individuals who donate blood, not only can that, if done repeatedly, lead to an iron deficiency, which can ultimately lead to restless legs, but also acutely, if someone donates blood, they can experience nocturnal leg cramps. And I had one lady recently where she just all of a sudden experienced nocturnal leg cramps that were quite prominent. And when we were trying to, figure out anything that might be implicated, clearly something brought this on. She said, well, I did have a visit with my primary care doctor where we were checking out several other things, and they took 8 vials of blood for the lab work that they tested. So turns out they actually took enough blood just to do lab testing that it kind of triggered nocturnal leg cramps in her. So it's kind of interesting. Other associations in addition to iron deficiency, pregnancy, which of course is a relative iron deficient state commonly. We'll talk a little bit more about that. Chronic renal failure, it's very, very common, almost ubiquitous with chronic renal failure. Peripheral neuropathy, as we talked about, fibromyalgia, and sometimes other pain conditions. You can definitely see both coexist. Sometimes you'll see restless legs misdiagnosed as fibromyalgia. Okay. Arthritis, as we mentioned, multiple sclerosis, and there are a lot of medications that can exacerbate RLS. Okay. In particular, as a group, the antidepressant medications, the SSRIs, but also the heterocyclic mirtazapine or Remeron. That, in fact, may even be the worst. And it's not just the SSRIs, but that's the serotonin-specific reuptake inhibitors, but there's also a class, the serotonin norepinephrine reuptake inhibitors, or SNRIs, and venlafaxine is a common offender in that class. Some of them, like fluoxetine and sertraline, interestingly can be more associated, it seems, even with periodic limb movements asleep, more so even than restless legs. So each one is a little different. If you have to treat someone with restless legs with an antidepressant, probably the best choice is bupropion, okay? It's different, it's a heterocyclic that works differently than the others. And if they absolutely need to be on an SSRI, citalopram may be the best choice. It seems to have the lowest effects on inducing restless legs. But also the neuroleptic medications like for bipolar and schizophrenia, these are meds like risperidone, ziprasidone, aripiprazole. That's a common situation. And for some reason, the neuroleptic medications, this can be early on, but it also can be kind of a later effect too. So somebody may have been on it for a while before you notice that. Some of the antiemetic medications like metoclopramide also can be associated, and it's because really in a lot of effects, they're also neuroleptic type medications in terms of how they act. Lithium, also a medication used for mood stabilization, more in the past than now, but you still definitely see that. It can be associated with it. And anything with an antihistamine effect, including tricyclic antidepressants like amitriptyline, which you definitely see sometimes for its sleep-inducing effects, that can be associated. All right, let's talk for a second about iron in restless legs. So when you're evaluating this, almost everyone that comes in with complaints of RLS, you want to know their iron status, even if they don't necessarily report a history of GI bleed or particularly heavy periods or things like that, because it can surprise you. You know, sometimes people have no history of any sort of ongoing blood loss or a history of iron deficiency, anemia, or anything like that, but they can have sometimes relatively low levels of the storage forms of iron, even though their serum iron level may be normal. Ferritin is the iron storage level, and that's especially the one that we look at. And anything less than 75 is definitely seen in association with a higher incidence of restless legs. So a lot of times we'll boost those individuals with iron supplementation, and oftentimes just by supplementing iron, the restless legs goes away. So before you ever start on any medication, that's why you definitely want to know what someone's iron is like. And so you can follow that ferritin level over time. Usually if I start somebody on that, then you follow it over time. But it's an important cofactor for dopamine synthesis, an enzyme involved in that cascade called tyrosine hydroxylase. Iron's an important cofactor, so when you're low on iron, that really slows that process down so you don't make as much dopamine as quickly. And some individuals, it's just from they're trying to be really good and donate blood every chance they get, and they go as soon as they qualify again, and that can keep them in a relatively iron deficient state. So sometimes you have to say, well, we need to really back off on our blood donation, and that I've seen many cases over the years where that does away with the restless legs. And you have to be careful too. Ferritin is also what we call an acute phase reactant. So if there's something else going on, say they've got some sort of infection or have had some trauma, I don't mean psychological trauma, more physical trauma, then you can see the ferritin level higher. So you always have to be careful and know the whole scenario when you're checking a ferritin, because that can throw you off. And sometimes you may even need to check it later in order to really know where that is. You see a lot of RLS in pregnancy, for sure. Even up to a quarter of all pregnancies, the woman can experience some RLS symptoms. In pregnancy, it's 2 to 3 times the prevalence of the general population. So it tends to increase throughout the pregnancy, much more common in the last trimester as compared to the first, but you can notice that even in the first trimester. Typically, it resolves within the first month after giving birth. And it's interesting, too, because people who have RLS during pregnancy and then it goes away after they deliver, you definitely see a higher incidence of restless legs in those individuals years later. So oftentimes, it can be a harbinger of things to come. So if I see a young woman and she's experienced RLS during pregnancy, sometimes I mention just be aware this can come back later. So if you start noticing issues years or even decades from now, it may be that restless legs. So try and keep that in your memory that you experienced RLS during pregnancy. If it's extremely severe, interestingly, the opioids may be the safest medication to give in this scenario. That being said, I don't do that. Anytime with pregnancy, there's no question the OBGYN is the head coach, quarterback, and all other positions in terms of deciding medications. So that's just if it's the case where something absolutely has to be done. But again, I would definitely have that ball in their court, not mine. Pediatric RLS, just wanted to touch on this briefly. You know, it can be very difficult to get the history, not only for this, but for a lot of things out of children. They're just not as good at describing, you know, what they may be experiencing. But there are definitely two things you see very frequently with pediatric RLS, and that is a family history. So definitely see a lot of either mom or dad or both have a history of RLS, and iron deficiency. Okay, so you definitely want to check the iron level in children. And if they have RLS and it needs treating, gabapentin it was developed as an anticonvulsant medication. It's not great as an anticonvulsant, but it's extremely useful for a number of other things. So a very low dose of gabapentin can be extremely effective even in children. So that's typically what we go to first line for that. RLS and periodic limb movements of sleep are also definitely associated with increased risk for cardiovascular disease, okay? Heart disease, 2.5 times more common in RLS patients. High blood pressure, 1.5 times more common. So, and that may seem sort of bizarre because you think, well, gosh, how would those two really tie in? But with RLS and periodic limb movements, and like the periodic limb movements, especially like during the actual movements, you get this increased sympathetic activity, okay? Meaning the sympathetic nervous system. And so that can, of course, lead to vascular effects that can lead to things like heart disease or high blood pressure. Congestive heart failure patients or patients with Cheyne-Stokes respirations, you definitely see more periodic limb movements of sleep in those individuals as well. And when you're looking actually during the periodic limb movements, those individuals can get a rise in their pulse rate and blood pressure too if you're monitoring that when they're experiencing that. So in periodic limb movements, I know really everybody in here probably already knows this, but it's these variable leg movements. It can be subtle, it can be just a slight twitch of the foot, or it can be pretty dramatic where the whole leg flexes, basically at hip, knee, ankle, the big toe can extend. Or some people even, it's more of a kick out. It's like it really is like they just kick the covers all of a sudden. It can be in one or both legs, probably more commonly in both at different times, but definitely in some individuals they say, no, it's more commonly in my right leg, or left leg. So you can certainly see that for unclear reasons. As you all know, definitely it can lead to significant amounts of arousals and feeling non-restorative sleep. So that's why it's important a lot of times when someone complains of non-restorative sleep or insomnia, and you've checked, they don't have an RLS history, they don't have obstructive sleep apnea, there's no other parasomnias. So a lot of times if you do the sleep study and you find an elevated periodic limb movement index, that alone is enough to cause daytime sleepiness and impairment without question. So another reason why you really need to do those in-lab studies for those situations. Very important. Periodic limb movements of sleep, that's not synonymous with restless legs, okay? You definitely see PLMs in a huge percentage of restless legs, almost all of them, 80–90%, but PLMs, it's the much bigger umbrella, okay? Many conditions are associated with PLMs. So, and just because you see that, it doesn't mean they have restless legs. You have to take that history to know. But a very common scenario. You see it more as people age, just like with restless legs. You don't see as many typically in children. But what it is basically from the central nervous system, you have constant activity, and it's designed so that there are all these breaks in there to keep that activity held in check, okay? So that's just part of the neural circuitry. That's like with tremor conditions. What that is typically deterioration of some of the neural structures associated with inhibiting that signal. So that's why you get that rhythmic movement with a tremor, and that's because of a release of that normal phenomenon that's no longer inhibited. The periodic limb movements, though it's different, it's not a degenerative condition, it's a temporary disinhibition of those lumbosacral spinal cord generators for movements. And you can see PLMs, you know, with sleep apnea, narcolepsy, RBD, you know, all those things. And one thing that I always like to point out too is if you do see it in kids, even though you don't see it as much in kids, the threshold is lower for diagnosing periodic limb movement disorder because it's not, you're not looking for that same index of 15 or higher. It's 5 or higher that's considered elevated in children. And usually in non-REM, okay? And typically the lighter stages of sleep, more stage N1 or N2. And don't forget too, you can have periodic limb movement, PLMW. That's not at all uncommon, where people who have restless legs or periodic limb movements will be sitting in a recliner in the evening, and then all of a sudden, you know, a leg kicks out, which is bizarre if, you know, you don't experience it yourself. You know, you may say, well, why'd you kick your leg? But they can't help it. You know, it's absolutely beyond their control, and they don't know they're going to do it until it happens. So, but things to differentiate from periodic limb movements of sleep, something we all experience at different times, those hypnic jerks, you know, where you're sleeping, and it can be anything. It can kind of be a whole body jump, or, you know, your legs fly up, or sometimes people just, you know, fling an arm out or draw it up, and you just think, wow, why did I do that? And of course, those are very common, especially in sleep-deprived states. And it doesn't have to be prolonged sleep deprivation. It can just be, boy, I had a rough night last night. You know, I was up most of the night, you know, that sort of thing. And then the next day, especially like when you're starting to go to sleep, take a nap, then you'll notice those sort of, in much more, and it can be repetitive. So it can be just isolated, or it can be repetitive. Nocturnal seizure activity. Some seizure disorders primarily happen during sleep, so you need to keep that in mind. And some of those can be quite bizarre. Some people will even experience, especially with frontal lobe seizures, something called a fencing posture. And that's where they kind of do this during their sleep, that sort of movement. So you definitely want to keep that in mind, but not necessarily that one in particular related to periodic limb movements, but movements during sleep. Of course, it's very common for individuals to have these, you know, along with just about everything else, confusional arousals, things like that, with sleep apnea events. So that's extraordinarily common. And then RBD, you know, it's not necessarily that you can only have one or the other, but certainly you can have both. And in general, you treat periodic limb movements or periodic limb movement disorder. The difference being there, periodic limb movements of sleep versus periodic limb movement disorder. Periodic limb movement disorder is a diagnosis of exclusion, okay? So if you have RLS, you don't have PLMD. You have RLS with periodic limb movements of sleep, okay? Or if you have OSA, in general, you don't have periodic limb movement disorder necessarily. You just have obstructive sleep apnea and periodic limb movements of sleep. Now, if your sleep apnea is fully treated, if everything's great, they're not symptomatic from that, you know, they've got really good control of their events, but then over time they say, but there's something, I'm still not fully restored from my sleep. You look back and look on their diagnostic study, if you see an elevated periodic limb movement index, then it's like, oh, okay, well, we may need to check this out. Sometimes you may even need to do another study on CPAP at their prescribed pressure, not necessarily a titration, but just know where they're going to be therapeutic and see. And then if you see all these periodic limb movements, that is periodic limb movement disorder. So you can have obstructive sleep apnea and periodic limb movement disorder. But you want to see if those PLMs are in response to the apnea events or just independent of that, okay? All right, let's talk about treatment for a few minutes, okay? There's non-pharmacologic therapies, and there are a lot of different things that people can try. I always advise people, when you're lying in bed, if you're experiencing the RLS issues, then don't try to suppress your legs or leg movements. One of the worst things you can do is lie there and think, okay, I'm not going to move them. That's going to keep you awake for much, much longer than if you get up and walk around and do something else, or if you just let your legs move a bit. So definitely you want to coach them on that and say, don't lie there and torture yourself. Nutritional supplementation with multivitamins. Some people experience significant improvement with that, okay? That's certainly a possibility. And one thing I should say with all these non-pharmacological therapies, it's very individualized in terms of how the person responds. So just because something works for one individual doesn't mean it's going to work for the next, okay? So, and a lot of times they've had this for years, so they've kind of experimented with some of these sort of things. They've seen an account of someone who felt better with using a multivitamin, so they've tried that, and they can tell you, no, I tried that and that didn't help, or a lot of the ones where it did help, you never hear about it, or you get a history and they say, well, I did have that until I started taking a multivitamin, or or whatever, and they say it's been years now since I've had that. But exercise is kind of interesting. Some people will feel that it gets worse with exercise. Some people feel like that improves things for them. So definitely see a lot of people where they say, gosh, I walked a lot today, or those kind of situations, and I really have a lot of the RLS on those days where I stand on my feet all day and walk around quite a bit. But then some people say, no, if I do okay if I go to the gym and do the treadmill for X amount of time. That really seems to help. So it depends on the individual. Stretching exercises can help, okay? So you definitely can get some benefit from that. Some people feel that kind of massaging their legs or feet or getting their bed partner to do that for them helps. You have to be careful with that, though. Of course, because of deep vein thromboses or any kind of situation like that, especially if somebody's been hospitalized or inactive, you don't really want to massage the legs, but that's just something that people will report to you. So several substances definitely tend to make restless legs worse. Caffeine too close to bedtime, alcohol, tobacco, definitely. All those kind of things can certainly exacerbate RLS, no question about it. So you can coach them on, if you are going to have caffeinated drinks, try and not do that past, midday or so. And caffeine's kind of interesting because different individuals respond very differently. The half-life on average is about 7.5 hours, but some people, that's like, and I'm sure you've heard this from different people, some people can drink caffeine right before they go to bed. It has no effect. Yeah, it's very common. But then some people, they say, gosh, if I have caffeine after 1 o'clock in the afternoon, I'm toast that night, and I cannot go to sleep. So very different from individual to individual. Sometimes mental alerting activities can be helpful. It's those really are distractionary type measures, so kind of getting your mind off of that sensation, that can help the individual falling asleep. Sometimes even some of the things that we use for insomnia can be helpful, like doing breathing exercises or progressive muscle relaxation. Some individuals will experience benefit from that. And certainly if they say, well, gosh, this really started 6 months ago, And then you say, okay, well, what changed then? Did anything change? And they may say, oh, I started on a new medication. It was an antidepressant. So, sometimes you can talk to the primary care doctor and say, well, definitely they're reporting significant RLS, and it seemed to coincide with when they started on medication X. If it's possible, bupropion or citalopram can be associated with lower incidence of RLS. So if that's a reasonable consideration, that might be something that could be considered for this individual. And then, like I mentioned earlier, if somebody's donating blood frequently, sometimes all you have to do is back off on that. All right, there's several different classes. If those measures don't work, then the iron therapy can help. And there are several different classes: the anticonvulsants, benzodiazepines, the dopaminergic agents, and then sort of the last line are the opioid medications. So let's talk about these a little bit in more detail. With the iron therapy, we always like to start with that, obviously, if there's an iron deficiency or even relative iron deficiency. Because don't forget, if your iron stores are low, that can be seen in association, even if that serum iron level is normal. So that's why you don't want to just check an iron level. But if that's the case, commonly we start off with oral iron, like ferrous sulfate, okay? And over the years, we've kind of changed a little bit with this. We used to say every day, take an iron tablet, this 325 milligram. Now we've realized it doesn't necessarily always take quite as much, so we start off with one tablet every other day. Or, if they're not that low, sometimes you may just say, well, 3 times a week, take this iron tablet. But it depends on the individual. They may need it daily, or they may need it multiple dosing per day, potentially. It's very helpful if they take vitamin C along with that, because vitamin C helps with the absorption of the iron, okay? And there are even formulations where it has both the iron and the vitamin C in with it. So that way it's just one pill that they have to take. It's helpful if they can take it between meals. They get better absorption that way. But in terms of side effects, the effects of it primarily are GI, unwanted effects. So it can cause GI upset. Iron certainly turns the stool a darker color, can lead to constipation in some individuals. So what you can do is, certainly if it causes any kind of GI upset, you can ask them to take it with meals. They'll get less absorption, but it tends to be better tolerated, okay? So you're still getting, most of the therapy in terms of the benefit, but hopefully less in terms of GI upset. And if it causes side effects, sometimes you just need to back off on how frequently they're taking it. Or sometimes you need to give something in conjunction, like stool softeners and so forth. Iron can be given as an infusion, so it can be given IV potentially. If that happens, you work with a hematologist really to do that. We do. So individuals who have trouble with absorption to start with, so people with inflammatory bowel disease or celiac, or a history of gastric bypass, because sometimes with gastric bypass, you no longer have the same absorption. Just like that can also affect B12, then you can also get effects with iron and get less absorption. So sometimes you need to give iron infusions, especially in those kind of situations. And as I mentioned earlier, definitely you want to follow those ferritin, the iron storage levels in terms of seeing how they do over time. And because you don't want to get someone in iron overload, so that you can be sure you know where you are. All right, there's a class of anticonvulsants, the alpha-2 delta ligands, that probably everyone's familiar with, gabapentin and pregabalin. Gabapentin, brand name was Neurontin, pregabalin, Lyrica, so you probably definitely heard about those. These used to be not necessarily first line. for RLS, and we're talking after iron if someone needs that, but say someone has normal iron levels and normal ferritin, normal iron storage levels, then we more commonly go to gabapentin now rather than the dopaminergic medications, primarily because of side effects. Gabapentin tends to be extremely well tolerated. Some people will notice after starting on it that they feel sort of woozy or unsteady. They can, especially like in low light situations. So, typically you have them take that an hour or so before bedtime. Some people will need to take it a little earlier. Of course, it depends on the timing of when they experience the RLS. But you want to definitely give that time to get in their system and absorb before they try to go to bed, because a lot of the medications, and I get this a lot when I talk to someone and they say, oh no, I've tried medication X and Y and didn't help at all. And you have to say, well, when did you take it? And they say, right as I was going to bed. Well, you've missed the boat at that point. So you have to tell them, no, you really need to take it at least an hour beforehand in order for it to have its effect. Because if you take it at bedtime, it's not going to really have its effect until well after you should have already been asleep. So the timing is critical. Usually I start off at a very low dose, only 100 milligrams, but definitely you need to increase that sometimes. For neurological reasons, individuals with peripheral neuropathy, commonly they're on twice a day dosing or even 3 times a day dosing, and at much higher dosages. So, but definitely you want to start off low. You wouldn't want somebody who complains of restless legs to be put on gabapentin 300 milligrams 3 times a day. That's likely overkill. They may need it at a higher dosage, but commonly they just need it at night and at a lower dosage. There's another formulation, gabapentin inacarbonyl. It's more extended release, so they just take their dosage around 5 or 6 p.m. at night, and you actually get better GI absorption with this form. The tough thing with it sometimes can be insurance coverage. You don't always get that, so typically you start off with the regular gabapentin. Pregabalin has better anticonvulsant properties, so if someone has both RLS and a seizure disorder, it can be a very good choice. It can be anywhere from 50 to 100 milligrams that they might need. It comes as a 75 also, and again at an hour or so before bedtime. But again, these individuals may need higher dosages as well. Very similar kinds of side effect profiles. They both can have that sort of dizziness, wooziness, and if they have that, a lot of times, as long as it's not presenting a danger to them, I always ask that they continue and press on for a week or so, because a lot of times those kind of effects go away with a little bit of time. So you definitely can notice that. But some individuals on these can start to notice edema, especially in the dependent areas like in the legs. They start noticing that down there. It can cause weight gain, and in some individuals it can lead to some depression. So definitely want to make sure they're not experiencing any of that. One advantage to this, to these medications, there's no augmentation or rebound, and we'll talk about that in just a second when we talk about the dopaminergic medication class. But again, it can be very helpful if somebody also has seizures. These medications are very good for other neuropathic pain, various different neuropathic pain conditions like peripheral neuropathy. Individuals who have fibromyalgia oftentimes are benefited from medications like gabapentin or pregabalin, certainly. All right, now let's turn our attention to the dopaminergic medications. In recent years, they've kind of taken some bad press just because of potential side effects, but a big part of that may just be because of dosing. I do see quite a few people who come in on these medications, or they've been on these medications and they say, but I just couldn't take that. And then when you dig deeper and you find the dosage, because these were developed as medications for Parkinson's disease, the dosages that sometimes they were put on are more for Parkinson's disease rather than restless leg syndrome, okay? Doesn't mean there's any association between restless legs and Parkinson's or development of Parkinson's disease. It's just they both work through the dopaminergic system, okay? So sometimes you can give a much, much lower dosage and they tolerate it just fine. So that's one thing with these medications. The levodopa, carbidopa, Sinemet, very old medication developed for Parkinson's. And years ago, people were using this for restless legs. But the difficulty with this is the vast majority of people, you know, anywhere from 2/3 to 3/4 or more, over time will develop augmentation. And augmentation is where, over time on these medications, say you used to just develop RLS at bedtime, say at 10 o'clock, then after several months, maybe even years, then you start to experience the restless legs at 4 or 5 o'clock in the afternoon. And then you're like, well, you know, it helps at night, but it's driving me crazy in the afternoon now. Well, that can be as a result of the medication, okay? And that has to do with, as you give these medications chronically, you can actually alter dopamine receptors, and those can get upregulated and things like that. So anyway, but so that's why you really want to reserve Sinemet or carbidopa, levodopa only for the most, the situations where it's really just very occasional, no more than 2 or 3 times a month. You know, and some people do have that where they say, you know, I have bad RLS, but it's only a couple times a month, you know. And so this can be a good medication for that because it's very effective for it. But if you give it nightly, then odds are they're going to come back in 6 months, a year, and they're going to have it earlier in the evening, okay? The other thing is rebound, which is a little less common than augmentation, but you can definitely also see it with chronic dopaminergic therapy. Rebound is where they have symptoms in the morning. So they may say, oh, no, it takes care of it at night, but then when I wake up in the morning, I have the RLS issues. So you can see that for sure too. And that can be, you know, up to 1/3 of patients treated with this over time. So, you know, or if somebody says, you know, the only time I notice it or the only time it bothers me is when we go on a really long car ride or something like that. Of course, you have to be careful because it can cause sedation. So if they're driving, you know, you don't want to experiment with that. But if they say, you know, oh no, I'm always in the passenger seat, then yeah, you can try it. You always just have to caution them about that and say, be aware, this is a possibility that it can be quite sedating. No, the question is, in a previous talk in years past, did I ever mention that if you use Sinemet or carbidopa, levodopa, will no other medication work? And the answer is no. I did not say that. That's what you're thinking of there is with the opioid medications. And we'll talk about that in just a second. Oh, no, it's a great point. So it's always good to illustrate that. Certainly fine to mention it twice. The dopamine agonists, in past years, you heard a lot about these being used for restless legs. And as I mentioned a few minutes ago, they, you know, you don't hear them being used as much, primarily because of side effects, but they can be extremely effective for it. And of course, being a neurologist by training, we're much more familiar with these and much more comfortable with giving them because we've given them at much higher dosages even. So these are very, very, very small dosages indeed. And this includes pramipexole, ropinirole, and the rotigotine patch, okay? And these are the typical dosage ranges that are effective for restless legs. If you push these toward the higher end of those dosage ranges and the individual says, I didn't notice any benefit, it's unlikely that it's going to work, okay? So you don't, I don't tend to press on above that. More commonly is like say you start someone on pramipexole 0.125, then they come back and they say, oh no, that helps a lot. I'd say it's 50% better. Then that's a good indicator, okay, this is going to be a good medication for this individual. We just have to tweak the dosage a little bit, okay? The patch, the rotigotine patch, very important to know, it comes in different sizes. Usually the 1, 2, or 3 milligram patch is what's effective for RLS. And let's say for whatever reason someone has the 3 milligram patch and you had decreased them down to the 1 milligram, it's important to go over this with them. They can't cut the 3 milligram patch into 3 pieces and that be a 1 milligram. Can't do that. Can't cut the patches, okay? So you have to use an intact patch for delivery mechanism and dosage. But very, very effective, as I mentioned earlier. Of course, the gabapentin and pregabalin also can be extremely effective. But these can cause side effects and various different side effects, okay? It can cause orthostasis, where you get dizzy when you stand up, or lightheaded from not maintaining the column of blood to the cerebrum for perfusion, adequate perfusion. So that's why people can kind of feel a little woozy. They also can definitely cause edema, particularly in the legs. Nasal stuffiness can cause headache. And those, if someone's on this or started on this, especially the nasal stuffiness or headache, if they have that, I always tell them, give it a little time, because again, like we mentioned earlier with some other things, it commonly goes away after about a week. Okay, so if they have that. But another interesting feature of these is with the dopaminergic medications, even up to 10% of people will all of a sudden develop prominent insomnia. So, and certainly that's not what you want. You don't want to try and fix restless legs only to give them insomnia. So, if they say, wow, I'm not noticing the restless legs, but I can't sleep anymore since I started taking this, it can be this medication. But at the same time, the flip side of that is more commonly it causes sedation. So I know that sounds bizarre, but it depends on the individual. So, and not only sedation at night when they take it, but sedation the next day, okay? So I always caution them about that. I always say, whenever you start this, let it be on the weekend where you're not driving to work or driving anywhere else, and then see that Saturday and Sunday what effect it has for you. Does it cause you to feel sleepy, like you need to drift off? And this is more at the higher dosages. You don't see it as much. You can see it at these lower dosages, but nowhere near as much as like with the Parkinson's medications. You can see excessive sleepiness during the daytime that's a frank sleep attack. And sleep attack, the definition of that is where you get sleep onset with no preceding drowsiness or warning. It's just where you don't notice you're sleepy and then just you drift off, okay? So particularly dangerous, of course, with driving or operating heavy equipment or machinery, things like that. So that's why you have to know, how someone responds to this. And I also recommend that too. So if they're on this and you need to adjust the dosage, I always have them adjust that dosage on the weekends. And again, remind them of all that and caution them, say, you can't run your tractor or plow your garden or things like that on this weekend. And interestingly too, because it affects the dopaminergic system, it can affect things like impulse control, okay? So it can lead to gambling or sexual urges and things like that. And the patch can actually cause skin irritation as well. So be aware of that. These you want to take about an hour and a half before bedtime. Some people need it 2 hours before. Augmentation is reported in up to a third of patients. I don't see that though. That's the literature. I don't see nearly that many with augmentation. I've definitely seen it, no question about it. You can see that. But oftentimes you can add a very small dosage earlier in the afternoon or evening in order to address that augmentation, okay? And if somebody has restless legs throughout much of the day where they've really experienced that, the patch can be quite effective for that situation, okay? And just in closing, I want to mention a couple other medications. Clonazepam, a benzodiazepine. We're not anxious, of course, to start a lot of people on benzodiazepines, but as one of the last resorts, it can be extremely effective for restless legs. So especially if they take it for something else, say someone has a lot of anxiety, clonazepam can be very effective in that situation. Typically at very low dosages even, it can be effective for restless legs. Of course, there's situations where you want to try and avoid that, things like obstructive sleep apnea that's not treated or undertreated, other pulmonary conditions, so forth. And of course, no question, that causes a lot of hypersomnolence or sedation potentially. And another thing that I always mention to people that they need to be aware of is certainly that can lead to kind of cognitive slowing. It dulls you. You know, the kind of thing where, you know, like if you ask someone something or mention something, it's like, wait, what? You know, that sort of, it doesn't necessarily present as a dementia, but it can certainly mimic those kinds of things. And then the last resort, the opioids that we talked about, and that includes tramadol, the synthetic. It's really reserved for last line therapy, very refractory patients. And as you mentioned, sir, earlier, yes, the difficulty with this is, and you definitely see patients where this scenario applies, they can come in and they've been treated with that for something else, or maybe this, not commonly, but usually something else, and they have RLS. Typically, after they've been treated with the opioids, it's very difficult to have the RLS respond to anything else. So again, another one of those reasons why you really have to be cautious about starting someone on opioids because of those kind of long-term lingering effects, you know, other things that it can affect, like the ability to treat this with anything else. So you can see, you know, yet another reason why, you know, you have to be very careful in that clinical scenario because of those possibilities. And then, of course, you know, a lot of potential side effects. You can help contribute to not only obstructive sleep apnea, but central sleep apnea development as well with the opioids. Sleepiness, you know, it can cause itching, constipation, because it can act specifically on certain receptors in the GI system to decrease motility, unsteadiness, those kind of cognitive effects as well. And I always just mention too that tramadol you don't want to use if someone has a seizure history, because it definitely lowers that seizure threshold and makes it much more likely. And interestingly too, tramadol also can cause augmentation. So, and I just listed that again as a reminder because that's a common list that people like to see. All right, thank you very much. Does anyone have any questions? Sorry, I know I kind of took up the whole hour.